I tried to say, look, you're North Carolina's board of directors. If I went to any company and said, I've got a deal for you, $8 billion in drawdown for Medicaid and other directed payments programs, $1.6 billion signing bonus, we're going to structure this in a way so that the state has to pay nothing. And if you said no to that, you'd be violating your fiduciary responsibility. That financial opportunity really woke the General Assembly up in a different way.
Welcome to The Other 80. I'm Claudia Williams. There's a quote I love that's attributed to playwright George Bernard Shaw. It reads, "Progress is impossible without change, and those who cannot change their minds cannot change anything." And really, it's the perfect quote to lead us into today's conversation. 2023 was a year of big healthcare headlines in North Carolina. In a historic bipartisan move, and 10 years after the ACA passed, the North Carolina General Assembly changed their minds and expanded Medicaid. Kody Kinsley is the Secretary of Health in the state, and he joins us in person at our recording studio at UC Berkeley School of Public Health to talk about what it took to get this done and how it's going so far. So please welcome Kody Kinsley to The Other 80. So I'm so happy to be in the studio today with Kody Kinsley from North Carolina. And for listeners, this is our first in-studio recording at the Berkeley School of Public Health, where we have this gorgeous space for online education. For those of you in the audience who don't know Kody, introduce yourself. What's important for us to know about you?
So it's my great privilege to serve as North Carolina Secretary of Health and Human Services. I grew up in North Carolina. I actually went to Berkeley for graduate school, ended up in D.C., worked at the Office of the National Coordinator for Health IT, and then popped over to the Treasury Department, was a presidential appointee, served 2 administrations there before coming home to North Carolina in 2018, and have been in the health space since then and took on this role near the end of 2021.
I think North Carolina's Medicaid has been very much in our hearts and on our minds over the last couple of years. You were the most recent state to pass a Medicaid expansion after many years of discussion and consideration. And the first question I have is, what did that take? What was the nature of the dialogue that pushed that across the line? And then we'll ask some questions about what's happened since.
Yeah, wonderful. Well, first and foremost, Governor Cooper's strategy here, which I think is what made all the difference in the end, was he built a non-traditional coalition of folks. And so it wasn't just hospitals, healthcare providers, healthcare consumer advocate groups that would all speak to why this was valuable to them, but it was also law enforcement who said, look, 60% of the people in our jails have a substance use disorder. We need healthcare, not handcuffs. It was businesses who said, look, if people are uninsured, that inevitably drives up the cost of my private health insurance that I try to buy for my employees. And it was county commissioners in rural North Carolina. Little known fact, North Carolina has the second largest rural population in the country when you think about the number of people that live in rural communities. And it was these small counties and their commissioners and their chambers of commerce who said, if people are 3 to 4 times as likely to be uninsured in a rural community, we're not going to be able to survive. Our rural hospitals are closing. Kids who grow up in small town North Carolina who go and become a provider and want to come home and serve their community can't, because they can't make a living without insurance reimbursement. All those voices added up over a long time. And I have to give a lot of credit to my predecessor, Mandy Cohen, who, this was a big priority for her, and she pushed really hard. COVID, of course, happened, and we had a lot of distractions through that. But I think what finally got us over the line in the end, after building that coalition, were 2 big things. One, the federal government, the Biden administration, put a enhanced FMAP on the line as far as an offer to people. And for North Carolina, that equated to $1.6 billion to invest in anything. I had been the assistant secretary of the Treasury Department. I took very much a financial lens on this when I talked to my friends in the General Assembly. And I tried to say, look, you're North Carolina's board of directors. If I went to any company and said, I've got a deal for you, $8 billion in drawdown for Medicaid and other kind of directed payments programs, $1.6 billion signing bonus, we're going to structure this in a way so that the state has to pay nothing. And if you said no to that, you'd be violating your fiduciary responsibility. That financial opportunity really woke the General Assembly up in a different way. And the second big issue, which has been an issue near and dear to my heart, it's partly why I came home to North Carolina in 2018, was there's a lot of people focusing on behavioral health. I think we all came out of COVID seeing depression and experiencing anxiety in a different way. And there was just frankly, a reckoning that we're never going to fix or even begin to fix behavioral health without insurance coverage. So credit to all those players to build the platform, to get the conversations right, the confidence in the General Assembly to do the really hard thing of changing your mind. That's not done in politics often, but to be able to point to the fact that we've had Republican presidents, Democratic presidents, Republican Congresses, Democratic Congresses, and the ACA is here to stay, and we need it to be, gave us the foundation to push the point. I would love if we would have done it 10 years sooner, but I'm kind of a person that will take what I can get and get it done as quick as possible.
And I love that economic argument. We all know that healthcare is one of the major, if not the major employer in a lot of rural areas. So there's a dollar and cents in terms of people's jobs. And then if you look at it at the state level and the fiduciaries, that's a brilliant way, I think, of taking it away from what had traditionally been the political arguments and bringing it back to dollars and cents and really just what makes sense for the state. So you started enrolling in December of 2023. How's it going?
So the Medicaid expansion bill was passed in North Carolina in March of 2023, but there was a trigger in it, and it couldn't go live until the budget passed because they wanted the governor to sign the budget. And so budget negotiations usually should have wrapped up in June. They did not wrap up until the end of September. And even at that moment, it wasn't everything that Governor Cooper wanted for the state of North Carolina, but he made the really bold decision to say, look, let's just let this become law. He's not going to continue to stand in the way of people getting the health insurance they need. So we officially had authority on October 2nd. We launched for enrollees December 1st. That's 58 days. Now, Claudia, you know this better than most. That's really fast turnaround for turning on eligibility systems, training eligibility workers. North Carolina has 100 counties. We operate decentralized eligibility in all 100 counties. It's a lot of training, a lot of effort, but the team just did amazing work here. So December 1st, 273,000 North Carolinians got fully covered and had to do nothing. They got a letter in the mail saying you're fully insured. We started enrolling about 1,000 people a day. And as of this morning, I checked, we're just shy, a couple people shy of 420,000 people enrolled. And we had, through our economic analysis, determined approximately 600,000 people were going to be eligible under expansion. And we expected to get to that 600,000 mark in 2 years.
Wow.
Instead, we are now just at 4 months, and we are more than 2/3 of the way towards our goal. And, not only are we getting there fast, it's going smoothly. Our average processing time is 35 days. A quarter of my applications and redeterminations, by the way, are going through without ever touching a human.
And we'll cover this ground, but I think it's important to note that over the last 5 years, North Carolina was one of the first states to launch whole person care initiatives combining medical and social care. Also launched managed care and Medicaid that had not really been there before, and finally expanded Medicaid. So it's been, let's just say, a busy time for you. And so we'll get to all of those pieces because I think they're an important tapestry that goes together to put a really different kind of system of care in place for the second most rural state in the nation. This all was happening during the same time that you, along with other states, were handling redetermination. What were the both challenges and opportunities of rolling out this expansion at the same time you were handling redetermination?
Yeah. So this is a little bit of that perfect storm opportunity, or what I call, and my team knows I say this too much, crisis-opportunity. And there are a couple of these.
That won't be the title. I'm just telling you.
Thank God. So we started unwinding in April, as everybody did. And as we started going through, when people would be determined ineligible at that point, we decided to put them into family planning. So we're holding them in family planning Medicaid, which, as you know, is a much higher eligibility threshold. And so, and we were tagging them for being eligible under expansion once we knew we could go live. It was all of those folks that built up over the course of that period of time, once we got to December, that we could then plop back into expanded coverage. That was at 273,000 people day one. That was a huge opportunity for us. As you recall, we had the bill signed in March. I would have loved for us to have been able to go live as soon as possible because I didn't want people to have to wait or have any gap in coverage. We tried to minimize that gap as much as possible. We leveraged ex parte data as far as SNAP eligibility information, pulling income data through Experian more than any other state in the country. And so we were using that information to find people as well within that are known to us to make it easy, which is also why we're able to put people right back in without having to run them back through the eligibility process. We also used other E14 waivers for our Medicaid geeks out there, such as North Carolina, I think was the second or third state in the nation to do continuous push for kids for 12, not continuous coverage, but we pushed kids forward 12 months. By extending coverage for kids by 12 months, which is almost the majority of our Medicaid population in North Carolina, I reduced the workload of my county eligibility workers by about half. They can focus on the redetermination of the adults and the expansion population coming in. It's also economically a smart move because kids, on average, are less risky and they drive down the risk profile of your pool. And so this is the big headline on redeterminations and the post-public health emergency period. This has been a painful but important natural experiment of how many opportunities we have to improve the Medicaid eligibility process. Mm-hmm. And I think the work that our federal partners have done, particular shout out to Dan Tsai, who's been amazing, has worked to figure out every possible way to use those flexibilities. Look, it's not broke. Let's keep it. Let's figure out every way to work with Congress and do whatever we need to do to keep these flexibilities in place. Because as I just outlined in just the kid waiver example, it's not only easier for people, it's great for a very shortened workforce that we're all struggling with. It's also really great for our financial pocketbooks on the average.
So interestingly, our first guest on this podcast was Mandy Cohen. She talked about many things. Of course, it was still in the throes of COVID, but we also focused a lot on the Healthy Opportunities pilots. And so this is a great opportunity to circle back and talk about what that looks like now, more than a year later. So just to remind listeners, North Carolina was the first state to take a comprehensive look at offering social services in addition to medical services through an 1115 waiver. You implemented, as far as I know, in 3 different, mainly rural regions. And in addition, and this is very different from what we saw in California, found these regional partners that would be the sort of bundlers and the organizers of those systems of care in those 3 regions, apart from the plan. So I'd just love to hear in broad strokes, what have you learned over the last 18 months? What have been some of the key takeaways? What is utilization and all of that?
Yeah. So we just actually announced in the last couple of weeks our 2-year anniversary of the pilots. As you said, 33 counties in North Carolina, mostly rural regions. In that 2-year period, about 20,000 individuals enrolled in the pilots, just over 280,000 services provided. We rolled the services in 4 domains: food, transportation, interpersonal safety, and employment. We have been rolling them out in phases. So the majority in the initial period in that 288,000 services are food. Here's the preliminary results, which are just astounding to me. $85 PMPM savings for those beneficiaries. That's big money. And think about it in the context of our already more underserved areas with harder to reach healthcare access harder to reach community-based organizations, and just as far as access to alternative health, it's amazing. All the same time, building, a community-based infrastructure that's from the ground up brand new. 75% of our community-based organizations are minority or women-owned throughout those 33 counties. So this isn't just about getting good access to what drives health over the long run. This is also about building that infrastructure and having a financing model that sustains it, that is in the balance a good value for the taxpayer. Pretty exciting. We've learned a bunch. While I'm glad we rolled out in a regional way, we're eager now to go statewide, especially now that we have good data. So we're working, within our context for 1115 to push in that direction. I think there's some services that we'd like to add to what we're offering right now. We think it's probably better to pay a few dollars before someone goes homeless than waiting until after they go homeless. And so I think those are all fail forward, fail fast kind of opportunities. The big area that I'm particularly also excited about here, and I think this is an important conversation in the field, is how do we also still make sure we're making good use of all the other, what I call foundational federal benefits in this space. So we've been working with the Benefits Data Trust to do a data matching exercise, looking at our Medicaid population, comparing it with our SNAP enrollees and our WIC enrollees. Here's two programs foundational to food and health. I mentioned earlier, maternal health's been a big focus for us. In the WIC program is particularly important. We found that if I had perfect enrollment of the folks that I have in Medicaid in SNAP, based off the eligibility swag, my SNAP population would double.
Yeah.
And so we're leaving a lot of dollars on the table that could go to that. And we're learning. So we're learning, now on some hands, people just don't know. We're learning that some people are like, look, doing that application at that interval is not worth the $25 benefit that I get. And we're also learning, which is not a surprise to anyone, that like the slight gyrations between like 138% of FPL versus 142% of FPL and the family size is exhausting.
Yeah.
And so people just get kind of stuck in the cobwebs, and our workers who do the eligibility work get stuck in the cobwebs. And so this is to me where I hope we're trying to push forward on a path of showing a broader value proposition here that would invite some major federal policy change to streamline and align some of these a little bit. That's a big dream, but yeah. I think we've got to do it, because this is just, we're showing that access to food is making a huge difference for people. We got to use every tool we have to make the best value of it.
We'll get a little more to this concept of braiding and blending funding, which is essentially almost trying to hide the complexity behind processes where the state folks will take that on and the beneficiary gets access to a more seamless kind of coverage. So if SNAP looks one way and Medicaid looks another way in another program, you try to make that work for the enrollee. But I think you're pointing to the fact that there are limits to how far you can take that. If the household definition is completely different as it is across all of these programs, if the eligibility cycles are different, if the way you validate your identity is different, those are just incredible barriers in front of those enrollees. I'm curious if you could wave a wand and make a couple changes that would make that so much easier for the beneficiaries. What would be your ask?
Well, first I'll say is we're all waving our wands at Congress, and that's if you are, figure out whatever the cap you want it to be, but if you are in Medicaid, in this context, you get SNAP automatically.
Love it.
Just make presumptive eligibility part of it. And look, we had a natural experience during COVID around presumptive eligibility, and we're trying to hold on to a lot of the application flexibilities as far as, voice signatures, not having to come into the office, blah, blah, blah. And Stacey Dean, who's the undersecretary at USDA that's over this space, has been phenomenal and flexible, and definitely comes from a how do we get this done perspective. But her hands are just tied by, congressional requirements, and I really believe that if you are in Medicaid by virtue of X, we can figure out what everybody's arguing about right now is like, what is the right clinical criteria? What's the checkbox to make sure someone really needs this? I feel like food's a good, safe place to start. That we can say we all need healthy food, and if you are in Medicaid because you're a pregnant mother, or maybe that would be a place to start. If you're in pregnancy Medicaid period, you automatically get SNAP, you automatically get WIC. No other questions, no other applications. Something like that, I feel like, is where we really have to push.
Yeah. One more question on the Healthy Opportunities pilots, and you might have answered this with the numbers. I know in some other states, a ton of work was put into passing legislation to enable the social services, because sometimes it required additional funding, submitting the 1115 waiver, getting the systems of care in place, only to find that the take-up was quite low. I think a lot more is needed in terms of really understanding what this looks like from the beneficiary perspective. Is it that they never knew about these services? Is it that it was too cumbersome to get them? Is it that they didn't think of themselves as a person who needed food, whatever that may be? But in the context of Medicaid whole person care offering these social services, have you had a similar experience where a lot of energy has been put into developing the system, but the take-up's not as high as you want?
I want to go back to the last question real quick, sorry.
Yeah,
because I really want to push on the WIC and the SNAP eligibility. And as I'm talking to my friends in Congress who care about, like, think about the number of eligibility workers we wouldn't need to use. Think about the process. Like, this is a government streamlining savings opportunity, and we could carve it out in such a way that would still only be in the space that we know would drive down cost for the government for the benefit delivery as well. Like, it's not just about more, easier, faster. It is an efficiency win too. Okay. On that spirit, how do we get people efficiently enrolled in what we call HOP in North Carolina, our Healthy Opportunities Pilot, hippity hoppity. What we have struggled with enrolling folks as fast as we would like. Part of what we definitely learned was, if you don't know about it, you don't go after it. And I think we also had to work really hard with our managed care organizations to really find the people and drive it to get them enrolled. There's a little bit of an adverse incentive here because the MCOs have to do work in processing these claims and various things. And so they want to grow the program in a way that they can manage that work. And so there was, I think, out of the gate, it was large that smoothed out some. And I think we have some learning to do, and this goes back to the standardized data definitions for some of these SDOH services to try to streamline the billing processes from behind the scenes. We have partnered with a number of entities to really get out the word and try to get folks enrolled to build capacity. We seem to be not quite hitting liftoff, but really pulling away from the pull. I suspect as we go statewide now, 2 years in, if we can get that approval and get into some of our more urban centers, then we'll be able to get that moving even faster.
Before we started this conversation, you mentioned that one of your important entrees into this work was through mental health. And I think every Medicaid program and every Secretary of Health across the nation has been really struggling with a confluence of issues, especially coming out of COVID. Workforce issues, pretty substantial increases in need that we're seeing. And I also think the long-standing need to take services more out into the community, in many ways demedicalize them while also providing the backstop of what's needed. I'd be curious to just hear, when you paint the picture of the opportunity space to improve mental health for Medicaid, what are some of the North Stars you're aiming for? And then we'll talk about some of the important initiatives you have going on in the state.
So first and foremost, I think that this is a particularly powerful moment in that everybody has come out of COVID, I believe, having been personally touched by some amount of loneliness and isolation leading to potentially depression, fear and stress to the point of leading to anxiety or members of their family, having routines disrupted. And so I think we're able to pierce through stigma on this issue in a slightly different way. And I think that's been the foundational thing holding us back. So for me, the North Stars here, to your question, are that behavioral health has to be non-negotiable. That when we are building out our social determinants of health strategy or our value-based strategy and investment, that behavioral health has got to be at the table. That second, we have to think about behavioral health not as specialty care, but primary care. 1 in 5 people have a behavioral health issue in a given year. I say 5 in 5 people have behavioral health. And so if you go into your primary care office provider and you're not getting depression screened, why not? Why aren't there conversations about access? And so how do we build it into the primary care injection kind of point as opposed to outside of it. We can't have a separate system. And then the last thing is, the last North Star is perhaps you get what you pay for. And North Carolina just increased behavioral health rates in its Medicaid program for the first time in over a decade. We put $200 million of state recurring funding into our system. That equates to nearly $1 billion fully loaded. We almost doubled our inpatient psych stay. We doubled our assessment. We did an analysis of where is the evidence, where are the, kind of choke points in the system, and how do we pay for what we need more of. And we're starting to see providers respond to those investments, which is really great. So anyways, lots more happening, but let me take a pause point and see what follow-up you have.
One of our fellow participants in this recent conference and someone who I've adored for a very long time is Susanna Fox. And she recently wrote a book called Rebel Health. And a core theme of that book and of her life's work is the power of peers. Linking this back to your conversation about mental health and capacity, your state has done tremendous work, North Carolina, around creating opportunities for peer-to-peer learning in both mental health and prenatal care. And love to have you talk about some of those initiatives and the underlying insight that they derive from.
So this is another great Medicaid story. In 2015, 2016, North Carolina really started to double down on investing in certified peers, using state funding to help support people that were in recovery with addiction and serious mental illness. It's a employment opportunity for them to get certified, and it gives them a sense of purpose and meaning and connecting in their community. And as we all know, from a health equity perspective and what we saw on the ground and during every type of effort in our COVID response, is that people with lived experience and trust in their communities can get more bang for your buck as far as getting support and buy-in and movement than anybody else. And so deploying those folks with state dollars, we built through that experience the financial argument that it was a Medicaid service. And so we stood up a Medicaid service in our state plan for it. So now our managed care organizations and our hospitals can reimburse for this service. And these people can make a wage, either being in a hospital waiting room in what we call a peer living room, to maybe catch that person that is just had an opioid overdose reversal with naloxone and have a conversation about their path to recovery and what that looks like for them. Maybe this is the moment we're going to get them in and they're the best person to have that conversation. Or we just stood up our 24/7 Pure Warm line as kind of an appendage to our 988 system so that, ideally between crises, again, how do we get upstream? Folks that are living with a serious mental illness, that are struggling, maybe the week hasn't been right, things have fallen apart, their group therapy, something happened, and they just need to talk to someone who knows what it's like and they're going to know better than anybody else, then that's a great person for them to call. This is an extensible workforce. We have, because we've been doing this for a while, thousands of people that have been trained and certified. We've not done as good of a job as we are now trying to do to get people actually employed and working and tie that together to build the right financial incentives into our system to make sure folks are moving in. But peers are great. I think there's a lot of variety of peers that are awesome. Thinking about family peers. This is another appendage I want to build onto my 988 system. When family members have a child who goes into crisis, it's so traumatic for their family, and we're trying to break these cycles of family mental health issues. How do we help connect those families to essentially navigators and caretakers? A big challenge ahead of us as a society right now is, what is the broadly scalable public health, behavioral health prevention model that we need to put in place? In the simplest of terms, like the sign next to the elevator that says, don't take the elevator, take the stairs. And there's some of that, in broad scale messaging campaigns, and, ASTHO has a model, and we're trying to think about what works, but I think we have to figure that out. What is the right intervention points for the broad population, and then certain age-based interventions that teach people resiliency, healthy coping skills, self-care, that give you a strong foundation for mental health and well-being that will hopefully prevent even more folks ending up in crisis.
You've touched on this a couple times, but I want to circle back in a more deliberate way to this question of workforce and in two data points. Your state, you have a $38 billion budget, 18,000 teammates, across the state and more than 20% vacancy rate. And this is true across the country. And if you talk to every Secretary of Health, it would be the same. So there's, first of all, just an acute need to recruit more people into state government. But we're seeing similar things when it comes to hands-on caregivers in all different kinds of roles, whether that's nursing or LPNs or peer caregivers. So I'd love to have you just talk about what do you see as some of the most promising strategies, both to recruit onto your team, but also to recruit onto the broader healthcare team?
I work in a state where I have a supermajority of a different party in my legislature. And if I can use data to define the problem, we can focus on that. We'll debate about the right solutions, but we move out of the political space and we focus on how to get stuff done. And then it becomes about implementation, and it's better, as opposed to kind of esoterically saying this is the thing we have to do because it's the most important thing and we care about. And so to that end, everybody is screaming about workforce right now. And so we convened our UNC system of public education. We convened our community college system, our Department of Public Instruction, our private colleges and institutions, a number of the other healthcare leaders to say, for the caregiving workforce, it won't surprise anyone. There were three things. One, nursing. Two, behavioral health. Three, direct care. These are the three workforces where we are on path to have the largest gaps, to cause the most problems. And so the ones that we have to fix. And it's not just about growing more people. While that's part of, getting more people into the pipeline, it's things like peers. And so we identified about 20 different kind of what we would call innovative solutions that aren't necessarily about net new money or net new bodies, but about how do we just transform the way we deliver this to be better. Peers is an important one for behavioral health. Another important one for behavioral health that we touched on a little bit is integrating care at the primary care level, and then supporting primary care providers to feel resourced appropriately to provide that level of care. A lot of behavioral health care can be provided at that level, does not need referral for specialty. And so supporting them. These things that kind of extend the workforce in this space are super important. There's also issues around making sure every nurse can operate at their fullest capacity, and those are issues across the country, and working on that too. But back at my department, we touch the life of every North Carolinian every day. Whether it is from the first birth certificate to making sure the water is clean, to dropping pellets from the sky to fight back at rabies in public health, to serve some of the most complex mentally ill folks in our state psychiatric hospitals, to being with families in those very tender moments at the time of death to understand what happened. It's a huge opportunity to pay back and pay it forward. And we have continued to compete in that space. But it's also a challenge for our General Assembly. They've got to invest more money for our workforce.
I'm going to close out with a question I've been asking every guest, and this is the give me free advice part of the conversation. So I recently joined Berkeley School of Public Health. We're here in the beautiful studio here on the Berkeley campus, and Berkeley itself has a tradition of activism and action. And the role I've taken as Chief Social Impact Officer here is really trying to bring that into the 21st century in the sense that we have the education mission, we have the research mission. What is the action mission for a school of public health? And there are a lot of ways that could be defined. I'd be curious, as the Secretary of Health in North Carolina, what advice would you give me about creating an action agenda for a school of public health? And you have one of the most prestigious and best schools in your own backyard. So what advice would you give all of us in schools of public health about how we can make more of a difference?
It breaks my heart that we kind of came out of the pandemic without a broader appreciation for what public health is and what public health does every day. And part of it, I think, is the fact that, when public health works, it's quiet, right? The water turns on, it's clean, the septic works, and that public health kind of rides along in the background. And it's these very, very low intrusive interventions to try to make a difference in people's lives. And so I love this frame of how do we make it more action oriented? And I think part of that is more active in telling the story, and trying to build that appreciation. But where the rubber meets the road, if it doesn't work, if people don't hear it, if they don't receive it, and you can't adapt to it, then it's not worth it. And to me, to really grow trust in this space and to get engaged, it is knowing who we are serving, and it is making our messaging malleable to every community one by one to try to get that work out there. And look, public health is an amazing set of tools. Look at car and vehicular accidents over the last 30 years. This follow the data, layered approaches. We are making cars safer, saving lives and reducing injury using a public health approach has been incredibly effective. And one of the things that we've been trying to do in North Carolina is apply that same model to firearm violence. And it's something as simple as we've learned, and I've learned, not to say gun violence, to say firearm violence, because that's more accessible to some of the folks I'm talking about. The other thing that I've learned is in sitting down and having really good conversations with conservatives is saying not use a gun lock, but to use a gun safe, because many individuals want to have access to their gun to protect their family. And if you say, gosh, you've got to use a gun lock, kids are going to die if you don't have a gun lock, you've lost them. But if you say use a gun safe that you can keep your firearm in and loaded and used, and use it when you need it, but only you have access to it. Usually my pitch here is I say, look, you want to keep your family safe. I want to keep your family safe too. And one of the leading causes of infant and young people's death in North Carolina is firearms. And so to me, the making public health active, pushing into spaces that we know will make a positive difference, but starting with that first word of, public health is public, and how do we meet people where they are is critical.
And I think you've repeated this throughout, that the measure of our communication is not whether we have a sentence we love, it's whether someone heard and could engage with what we're sharing. And often that means choosing different language and framing things in a different way, because that's how we truly create connection and create change in the world. And what a pleasure to have you here in the studio as my, as you said, guinea pig. It's been so much fun. And I really appreciate your coming in to share about all the work you've been doing. And I hope you have a chance to take a small break here and there, because you sure have been doing a lot.
Thank you. It's been a pleasure. It's great to see you.
I left this conversation thinking a lot about how change happens. After bitterly opposing Medicaid expansion for many years, North Carolina legislators changed their minds. It's a rare move these days. We are all so used to seeing legislators dig in their heels on their own side of the line. But conditions shifted, arguments evolved, new coalitions emerged, and suddenly the line in the sand washed away. Change became possible. Often we think if we just found the right words or the more convincing argument, we could change people's minds. But what this conversation showed me is that the conditions for change are just as important, or more so. This podcast was created by me, Claudia Williams. My podcast producer is Avery Moorcloss. Check out the show notes for more information on Kody Kinsley and his work in North Carolina. There is more information on my background, this podcast, and our guests on our website, www.theother80.com. Until next time, I'm Claudia Williams.